Let's talk about a bacterium that's had a real identity crisis. For years, we saw Finegoldia magna in cultures and kind of thought, probably just a skin contaminant. But it turns out this organism is a serious clinical culprit. And today, we're going to unpack its fascinating journey from a harmless commensal to a recognized pathogen.
So, this was the big debate for a long time. You'd find Finegoldia magna in a deep-seated wound culture, and the question was always the same. Is this real, or did some skin flora just hitch a ride into the sample? It's a classic clinical micro conundrum, right? Well, spoiler alert, we now have a very clear answer, and it's all thanks to some game-changing tech.
All right, before we dive in, just a quick note on where all this information is coming from. We've pulled together all the latest knowledge for this explainer using a Gemini deep search, digging through a ton of scientific literature and clinical guidelines. So everything you're about to hear is current. And hey, if you want to geek out and check the primary sources yourself, all the citations are right there for you in the linked notebook document.
So here's our game plan. First, we'll look at that journey from contaminant to culprit. Then, we'll get into how to actually identify it in the lab. After that, the clinical picture. What diseases does it cause? Then the really practical stuff, treatment guidelines. We'll also spend some time on the lab's critical role in all this, and we'll wrap up with prevention and what's next on the horizon.
Okay, let's kick things off with Section 1, from contaminant to culprit. And really, the story here isn't about the bug changing. It's about us, our technology, and our perspective, finally catching up to what this organism was doing all along. So, what exactly is Finegoldia magna? Well, at its core, it's a gram-positive coccus that absolutely hates oxygen. It's an obligate anaerobe. It's a totally normal part of our skin, mouth, and gut flora, just hanging out. But the key thing to remember is this. When it gets a chance to break through our defenses and go somewhere it shouldn't, it is hands down the most pathogenic of all the gram-positive anaerobic cocci, or GPACs.
So what was the big turning point? It was really two pieces of tech, MALDI-TOF MS and 16S rRNA sequencing. I mean, think about it. Before MALDI-TOF, identifying these slow, fussy anaerobes was a real pain. But MALDI? It's like a bacterial fingerprint scanner. Suddenly, labs could get a reliable ID in minutes instead of days. And once that technology became widespread, the blinders came off. We started seeing Finegoldia magna pop up in all these serious, deep-seated infections, especially prosthetic joints. And we realized, wow, this bug has been here, causing trouble all along. We just weren't good enough at finding it.
All right, let's head over to the lab bench for Section 2. We're going to look at how we actually identify this bug, its taxonomy, what it looks like, and then we'll get into its pathogenic toolkit, the special weapons it uses to be so effective at causing disease.
You know, you can really trace the history of microbiology just by looking at this organism's name changes. It started as Diplococcus magnus way back in 33. Then, as our methods got better, it became Peptostreptococcus magnus. But the real revolution was 16S rRNA sequencing. By looking at its genetic code, we realized it didn't belong in that genus at all. It needed its own. And so, in 1999, it became Finegoldia magna, a really fitting tribute to the legendary anaerobe expert Sidney Finegold.
Okay, for all my fellow lab folks, here are the key identifiers you've got to look out for. First, the gram stain can be a little deceiving. It's a gram-positive coccus, sure, but it forms these pairs, tetrads, and grape-like clusters that can really make you think staph. Second, you've got to be patient. This is a slow grower, so don't toss your anaerobic plates too early. It might take up to 5 days to show up. And here's a big one. It's resistant to SBS. That means it can actually grow right in your blood culture bottles. So you have to be vigilant and not just dismiss it as a contaminant.
So let's open up this pathogenic toolkit and see what's inside. It's got some really clever tools. First, there's FAF, which is its grappling hook for sticking to our tissues. Then it pulls out SUFA, a protease that acts like a wrecking ball, breaking down collagen so it can invade deeper. To hide from our immune system, it uses something called protein L, which basically messes with our antibodies. And the real kicker, especially for device-related infections, it forms biofilms, that slimy protective shield that makes it so hard for antibiotics and immune cells to get to it.
Okay, so we know it has the weapons. Now for Section 3. What kind of damage does it actually do? When Finegoldia magna goes on the attack, what does that look like clinically? You might be surprised by just how broad the spectrum of disease really is. I mean, just look at this range. On one end, you have the more common stuff, skin and soft tissue abscesses, nasty diabetic foot ulcers, and surgical site infections.
But then it gets much, much more serious. We're talking prosthetic joint infections, chronic osteomyelitis, and even life-threatening conditions like necrotizing fasciitis and infective endocarditis. The part that really drives its importance home for me is in PJI, where you often find it as the only organism. That's a smoking gun. It proves it's not just a bystander, it can be the sole villain.
All right, moving on to Section 4, treatment. This is where things get really practical, but also a bit tricky. There's a really important resistance pattern we need to talk about that has major implications for how we treat these infections.
Okay, if there's one thing you take away about treating Finegoldia magna, it is this: watch out for clindamycin. Look at these resistance rates. Resistance to metronidazole and penicillin is still pretty rare, thankfully. But clindamycin, resistance can be over 25%, and it's highly variable. The bottom line is, you absolutely should not be using clindamycin empirically if you have a serious infection where Finegoldia magna might be the cause. You just can't count on it working.
So let's look at some specific guidelines, starting with the Dutch approach. They really focus on syndrome-based treatment. For something like a complicated skin and soft tissue infection, they're reaching for amoxicillin clavulanic acid. If you have a confirmed prosthetic joint infection and you know your isolate is susceptible, high-dose intravenous benzylpenicillin is the workhorse. And you see a pretty similar story when you look at international guidelines, for example, from the IDSA. Again, the focus is on good, solid anaerobic coverage. You see beta-lactams and metronidazole showing up over and over. What this really underscores is the importance of thinking about anaerobes up front, especially with PJI. You can't just assume your standard empiric regimen is going to cover Finegoldia magna. You might need to specifically add something for it.
Now, what about kids? Well, this is a huge knowledge gap, honestly. The data is just really sparse. So for the most part, pediatric treatment is extrapolated from adult data and general principles for treating anaerobic infections. You'll see regimens like ceftriaxone plus metronidazole or ampicillin-sulbactam. But we have to be honest here. We're making educated guesses, and we desperately need more pediatric-specific research.
Okay, Section 5. This one is a big public service announcement for everyone in the clinical microlab. We need to talk about antimicrobial susceptibility testing for Finegoldia magna, because right now the situation is, well, it's complicated. There's a major breakpoint gap we have to navigate.
And here it is. This is the headline. As of 2024, if you're using EUCAST, there are no specific clinical breakpoints for Finegoldia magna. Let that sink in for a second. We don't have an official species-specific yardstick to call it susceptible or resistant. And that, of course, has a huge impact on how we test and how we report our findings to clinicians.
So what's a lab supposed to do? Well, for now, we have to use these interim, non-species-related PK/PD breakpoints from EUCAST. They're not perfect, but they're what we have until the species-specific ones hopefully arrive in 2025. But here's the most important part of this. When you report a result, don't just put S or R. You must report the actual MIC value. Give the clinicians the raw data so they can use their clinical judgment, because we're all operating in a bit of a gray zone here.
Okay, let's wrap this up with our final section. Prevention and a look to the future. And this is really exciting stuff. We're going to talk about a major gap in our infection control practices and a brand new species that's been hiding in plain sight this whole time.
Here is a huge issue for infection prevention and control. Think about standard surgical prophylaxis, especially for orthopedic surgeries. What do we almost always use? Cefazolin, right? Well, guess what? Cefazolin has zero activity against Finegoldia magna. So we're putting in these expensive new joints while giving a prophylactic antibiotic that completely misses one of the key pathogens that can infect it. This is a massive gap, and it's forcing a serious conversation about whether our standard prophylaxis regimens are good enough.
And just when you think you've got a handle on this organism, genomics comes along and throws us a massive curveball. It turns out that what we've been calling Finegoldia magna all these years probably isn't one species. It's two. When you compare their genomes using average nucleotide identity, or ANI, the similarity is only around 90.7%. The cutoff for being the same species is 95 to 96%. So we're likely looking at a whole new species, which for now is being called Finegoldia noracea.
This leaves us with a really big question, doesn't it? Are we dealing with one pathogen or a whole species complex? It means that all our past data on how virulent it is, its resistance patterns, it's all based on a mix of two different things. The next big job for us in the microworld is to figure out how to tell these two apart so we can truly understand what each one is really doing.
And that's our deep dive on Finegoldia magna, from a dismissed contaminant to a complex of emerging pathogens. Hey, if you enjoyed this and want to keep up with more topics in clinical microbiology, do me a favor and hit that subscribe button. And I really want to know what you think. Have you been seeing a lot of this in your lab? What are your thoughts on that prophylaxis gap? Drop it all in the comments below. Thanks for tuning in.